Hello everyone, myself Dr. Parth Goswami, and today I'm going to teach you about the tumors of infancy and childhood. So we will discuss about the infant and childhood tumors, and we will discuss in detail about the morphology of neuroblastoma, which is a tumor from the neuroblast. Alright. So we will see the pathogenesis and pathology of tumor and tumor-like condition of infancy and childhood. So we know that tumors could be benign or malignant. Benign tumor is more common than the malignant tumor in infancy and childhoods. However, the malignant tumor constitute the second most common cause of death in a children between the 4 and 14 year. And which are the tumor-like lesion? Means it's not a tumor but tumor-like lesion. That is the choriostoma, heterotopia, or hematoma. So what is heterotopia or choriostoma? So it means the name itself suggests, hetero mean outside. Topia means presence. So here the presence of microscopically normal tissue or cell in the abnormal location. For example, the pancreatic tissue present in a intestine, adrenal cell present in a kidney, ovary, or anywhere else. So this is called as a heterotopia at the site where they should not present. That is not much important, but it's not a tumor that you need to recognize, right? Hematoma. Now hematoma is somewhat different. Means here there is a focal mass or focal overgrowth of cell and tissue that is native or indigestion to the organ in which it occurs. Means the cellular elements are mature but they are overgrowth and identical to those found in the remainder of the organ, but they do not have a normal architecture of the surrounding tissue, right? Now there could be four benign neoplasms in a infancy and childhood period. There could be origin of four benign tumor: hemangioma, lymphangioma, teratoma, and fibromatosis. These four benign tumor are common. So first, hemangioma. Oma suffix is added to the benign tumor. So hemangioma means benign vascular tumor. So it is the most common tumor of infancy and childhood. The common side, we know that it could be a skin, face, or scalp. Here it involving the leg, right? And it is flat to elevated, irregular, and red blue colored. The red blue colored is because it is a vascular tumor, right? There is a lots of proliferation of capillaries in this tumor. So it is flat elevated and it regress spontaneously, means without treatment spontaneously it can regress in majority of the patient. Here you can see that regression occurred. Now lymphangioma. Oma means benign tumor, lymph means lymphatic channel. So it is a benign tumor of lymphatic tissue that could be seen in the skin or deeper tissue. It could be cystic or cavernous type. The size of lesion increases after birth. Now teratoma. So teratoma is a mature benign tumor, right? See, teratoma could be immature or mature, but in most of the patient it is mature one. Mature one means the differentiation of the cells occurred. And what is the meaning of teratoma? The meaning of teratoma means more than one germ cell layer cells are present. Means skin, bone, cartilage, tooth, variety of tissues, adrenal gland, intestinal gland, respiratory epithelium, variety of germ cell layer glands epithelium is present. Means more than one germ cell layer cells are present. That is known as a teratoma. And mature means differentiation occurred. So it's a well differentiated and usually cystic one. Less than 4 months, it is commonly seen. It is commonly seen in a children less than 4 months. And the common region is sacrococcygeal region. Here you can see that large cystic teratoma that is seen in sacrococcygeal region. So 40% teratoma are sacrococcygeal one. The fourth benign tumor in a children is fibromatosis. Name itself suggests here you have a proliferation of fibrous cell, spindle cell fibroblastic proliferation. It is a solitary lesion and it is usually benign. But sometimes multifocal lesions means at multiple site it is present, that is usually aggressive, or else it's a pure benign. So these are the four benign tumor of infancy and childhood: hemangioma, lymphangioma, teratoma, and fibromatosis. Fibromatosis is a benign tumor of fibrous tissue. All right. Now let's outline the malignant neoplasm in a children. So it can be divided in three age groups. The first is 0 to 4 year of age group, in which the commonly seen malignant tumors are acute leukemia. So that is the uh, blood stem cell tumor. Means acute leukemia could be acute myeloid or acute lymphoid leukemia, in which there is a more than 20% myeloblast or lymphoblast present in the peripheral blood smear. CNS tumors. Then lymphoma, that is the lymphoid tissue malignant tumor. Neuroblastoma, that we are going to discuss in today's lecture. Retinoblastoma, sarcoma. Sarcoma means malignant mesenchymal tumor, or teratoma. Teratoma could be malignant as well if immature elements are present. So these malignant tumors seen in a 0 to 4 year. In a 5 to 9 year of age group, the common malignant neoplasm seen is acute leukemia, again myeloid or lymphoid, then lymphoma, Wilms tumor, neuroblastoma, retinoblastoma, Ewing sarcoma, and hepatocellular carcinoma. So this is added. Ewing sarcoma is a malignant bone tumor, and hepatocellular carcinoma is a malignant tumor arising from the hepatocytes. Now, in a 10 to 14 year of age group, the malignant neoplasm that is seen is acute leukemia, Hodgkin's lymphoma. That is one of the malignant lymphoid tissue tumor, right? So lymphoma could be of two type, Hodgkin or non-Hodgkin lymphoma. So here Hodgkin lymphoma is commonly seen. Osteosarcoma, that is a malignant bone forming tumor. In a bone, if the tumor is forming a bone, then it is osteosarcoma. Hepatocellular carcinoma, thyroid carcinoma also can be seen in this age group. So as the age advance, osteosarcoma and thyroid carcinoma chances are also more. All right. Now, how these all malignant tumor differ from the adult malignant neoplasms, because all these tumor can occur in adult as well. So how it is differ? So usually they differ in a genetic abnormality. They usually seen as a part of familial syndrome, and stem cell defect could be there because of which this tumor arise, and it can regress or differentiate into mature element. That is important one. It can convert into mature elements, so prognosis become good if if it is differentiated into mature elements. All right, so that's all about the outline of various tumor that is observed in infancy and childhood period. Now we will discuss the neuroblastoma in a detail, which is one of the very important and more common tumor that is seen in infancy and childhood period. It is one of the malignant tumor. So it is a neuroblastic tumor. Name itself suggests it is neuroblastoma, means neuroblastic tumor. It arises from the primordial neural crest cell. Now this neural crest cell is one of the stem cell which give rise to various nerve elements, ganglion, neuron, melanocyte, cartilage, bone, etc. Right. So this tumor arises from this primordial neural crest cell, and it is a tumor of sympathetic ganglia, or it is seen in adrenal medulla. In adrenal medulla, it is commonly seen, and it can be seen in sympathetic ganglia, and it's derived from the primordial neural crest cell, which is one of the stem cell. It is a most common extracranial childhood solid tumor, and the common genetic mutation associated is ALK gene mutation and amplification of MYC gene. This MYC gene leads to excessive nuclear transcription, right? So amplification, overexpression of this gene will lead to over cell growth, over nuclear transcription, and that's why neuroblastoma arise. Now, morphology of neuroblastoma. Morphology means gross and microscopic appearance. Gross appearance means that is seen by naked eye. So, if we talk about the gross appearance, then on cut section, this particular tumor is very soft. It brain-like tissue is there, and it is grey tan colored. Sometimes necrosis, hemorrhage, and cystic change can be seen secondarily. So here you can see a cystic change along with presence of necrosis and hemorrhage. This is the gross appearance. It is soft tumor. 40% occur in adrenal medulla. It can occur at the sympathetic chain as well, as we have seen in our previous slide, right? So it can be seen in the paravertebral region of the abdomen. It can be seen in posterior mediastinum. It can be seen in the neck, brain, or pelvic area. So sympathetic chain can be involved. So it can involve sympathetic ganglia. If we talk about the size, then it could be a very small nodule to a very large tumor. Weight maybe more than 1 kilogram, right? So it could be small to large tumor. The size markedly varies, and the weight also. Majority tumor are silent. They are usually not symptomatic, and it regress spontaneously. So although it is malignant, it can regress spontaneously. Now, microscopic appearance. If you take a biopsy and do the histopathological examination, then what is the microscopic appearance? So these particular tumor cells arrange in a sheet pattern. They are arranged in a sheets, homogeneous sheets, and the nucleus is very dark, and small primitive tumor cells are present. Nucleus is very dark, and they have a scanty cytoplasm with poorly defined cell border. See, these are the neuroblastoma cells. This is the photomicrograph of neuroblastoma, and this is a schematic diagram from Hirschman book. So see, these blue colored cells are undifferentiated neuroblastic cells. They are having dark nucleus and scanty cytoplasm. You can't see a cytoplasm. They are very small, round, and they doesn't have cytoplasm. Very scanty cytoplasm. Here you can see a small round blue cells. So it is one of the small round blue cell tumor. So this is the undifferentiated neuroblastic tumor cell with scanty cytoplasm and dark blue nucleus. Here you can see a dark blue nucleus. Now, if you see characteristically, then they have a characteristic appearance around the centrally placed neuropile. See, the tumor cells are arranged concentrically around the central place. That is the field with neuropile. So this is the center area which is filled with neuropile. What is neuropile? The neuropil is, they are the fibrillary material. They are the eosinophilic fibrillary material which represent the neuritic process of neuroblast. So the neuroblast neuritic process will stand as a neuropile. So the center one is neuropile. So around the neuropile, there is a concentric arrangement of these undifferentiated tumor cell that is known as a Homer-Wright rosette. That is known as a Homer-Wright pseudo rosette. Why the term pseudo is mentioned here? Because the true rosette doesn't have anything in a lumen. Here in the lumen, neuropile is present. That's why it is pseudo rosette. So it is a Homer-Wright pseudo rosette and it is non-specific asterix positive. If the tumor is aggressive, then mitosis and pleomorphism, marked pleomorphism is present. Pleomorphism means variation in size of nucleus. If you do the electron microscopically, then these cells, small membrane bound catecholamines are present. So, in an electron microscopy, the cells can have catecholamine containing secretory granules in their cytoplasm. So, along the membrane, the granules are bound, that contain the catecholamines. All right. Now, once the neuroblastoma tumor mature, if the maturation occurs, then the prognosis is good. So for example, see, this is the primitive tumor. Here there is a no differentiation, no maturation. But if the tumor is mature, means mature tissue is formed. For example, if presence of Schwann cell, fibroblast, or ganglions, then it is mature tumor. That is called as a Schwannian stroma. And prognosis is good if the elements are matured. There are two examples of matured neuroblastoma, ganglioneuroblastoma and ganglioneuroma. So first ganglioneuroblastoma. So along with primitive neuroblastic cell, which is round blue cell. See, this is the round blue cells, right? So along with malignant neuroblastic cell, we have an admixture of ganglion cell. This is the ganglion cell. See, these all are the ganglion cell. So how ganglion cell is characterized? As you can see, this ganglion cell is very large cell as compared to neuroblast, and they have abundant cytoplasm, which is very scanty in neuroblast, and they have a large vesicular nuclei and prominent nucleoli. So this is the cell having abundant cytoplasm and vesicular nucleus and very large cell. So this is the ganglion. So that's why it is known as a ganglioneuroblastoma. Prognosis is good as compared to neuroblastoma. Now still if differentiation occurs, then ganglioneuroma could develop. So it is a most mature form of neuroblastoma, right? Here you can see that ganglion cells and Schwannian cells are present. This is the Schwann cells, fibroblastic cells. So here two elements are present, ganglion cell and Schwann cell. That's why it is known as a ganglioneuroma, and it's having a most favorable outcome. So as the maturation occur, outcome is good. So the most immature tumor is this neuroblastoma, which having only neuroblastic cell, undifferentiated round blue cell with scanty cytoplasm. And after that maturation, if occurred, ganglioneuroblastoma is there, in which ganglion cell and neuroblast are seen. And still further maturation, if occurred, then it is ganglioneuroma, in which Schwann cell and ganglion cells are present. All right. How the patient present clinically? This form of tumor, patient clinically present with usually abdominal mass. So if the children present with large abdominal mass, then first differential should be neuroblastoma because it is more common. And then second one is Wilms tumor. Patient could have fever and weight loss because of malignancy. Urine, vanillin, mandelic acid, and HbA is positive because they are the catecholamine products. So it can be excreted in a urine. If we talk about the prognostic factor, then in a neuroblastoma, if it is stage 3 and 4, then prognosis is unfavorable. If the patient age is more than 18 months, then it is unfavorable. It is having unfavorable outcome. High mitotic activity obviously suggests that tumor is aggressive and the outcome is unfavorable. Poor prognosis. Swanian stroma, if absent, then it is having poor prognosis because the Swanian stroma, Swan cells indicate the maturation. So if the Swan stroma present, then prognosis is very good. But if it is not present, then prognosis is very poor. MYC gene amplification usually suggests poor prognosis. And chromosomal loss if present, deletion if present, then prognosis is poor. So that's all about the neuroblastoma tumor, which is the most common tumor of infancy and childhood. So that's all about the today's lecture, and this is my reference books for the today's lecture. I hope you have enjoyed this particular video. So we will be right back with a new video. Till then, take care and bye bye. Thank you very much. Thank you. If you have any question, then you can ask me in a comment section. Thank you.